marker, sorry?
Yeah, they have a radio opaque marker distally.
Oh yeah, the tip. Yeah, sometimes it just depends on the make of the NG tube. Sometimes they don't always have the dense tip.
Okay.
Yeah, so good. Yeah, and you commented on all the other features. So in your pacification in the lungs. Yeah, and so this was a scoliotic patient. As you can see, they've got a long segment spinal fixation. And in these types of patients, it can be quite difficult to site the NG tube correctly because of the neck and the chest positioning because of the scoliosis. So they tried again, and on the third attempt, they managed to site the NG tube correctly. On this image, we can't really see the tip, but we can see it's below it crosses the hemidiaphragm, and it's on the left side. Okay, so good. So this is just an NG tube checklist. So, I mean, on the wards, if they are able to obtain an aspirate, which is of alkaline, then that's fine. But if they can't, then patients will tend to go on to have a chest X-ray to confirm the positioning. And yet, you need to make sure that it follows the path of the esophagus, bisects the carina, crosses the diaphragm in the midline, and then is seen on the left side below the diaphragm. So this is just a checklist that can be used. Okay, so this is case 3. Are we still with candidate 1? Or,
yeah, I'm here.
Okay, good. So you can present this case, please.
Yeah. So I've been provided with a frontal radiograph of the thorax and the abdomen. First, I would like to comment on the tubes. I could see the one catheter going inferiorly to above. I think this is a umbilical venous catheter because it is not going down, it's going directly on the right side of the patient, going on the right side of the vertebra in the right paravertebral region, and going very high up into the area of the first intercostal space. So I'm thinking of a malposition umbilical venous catheter with very high position. Mm-hmm. And apart from this, there is another tube that is going parallel to this one. But there is no kink in the tube, but it is going parallel to this one. Yeah. And it is present at the level of 1, 2, 3, 4, 5, 6, sixth right intercostal space. Yeah, I couldn't make out what tube is this one. There is one more tube that is coming from the cranially and going into the abdomen. Yeah, this can be any ventricular peritoneal shunt. And apart from this, there are a few other tubes in the left quadrant of the abdomen overlying the abdomen. And apart from this, I would like to go systematically now that I have sorted the tubes, except for the horizontally lying tube, which I don't know whether it is umbilical arterial catheter because I could not see the going down and coming up, but there is a definite malposition of the umbilical venous catheter. So apart from this, I would like to go through airway. The trachea appears normal, breathing, the lungs appear normal, and there is and the cardia appears normal. There is no blunting of the costophrenic angles. Bones appear normal, no focal lesions or lytic or fractures. And the abdomen, I could see the stomach bubble and the other bowel shadows. No evidence of any pneumoperitoneum, no evidence of any airflow levels to such a obstruction. So I'm thinking in terms of a malposition umbilical venous catheter which has gone very high up. I think it has gone through the inferior vena cava, through the right atrium to superior vena cava very high up. I could not make about this horizontal place to this might be another malposition umbilical arterial catheter. And I will inform the findings to the referring clinician for urgent referral. And I would like to do the normal position, reposition the catheters to prevent any further damage, because this malposition might predispose to thrombosis or any other complications.
Yeah. Are there any other lines and tubes that you probably haven't commented on? So these were external.
Yeah, these were external. There is a VP shunt that is there on the right side. I think it is coming from cranially into the abdomen. Yeah.
Can you see an endotracheal tube?
Yeah, okay. Yeah, I can see. I think it has gone into the right bronchus. Yeah, it has gone below the level of carina, but I couldn't see any collapse of the right lung, any segmental collapse. It has gone beneath the level of carina. Yeah, I think I missed that one. I think these are to be positioned correctly before they do further undergo any other procedures.
Yeah. So yeah, you commented on the umbilical venous catheter, which is too high up, and it's projected over the superior vena cava. So that's abnormal. So this second line was actually, this patient actually had 2 umbilical venous catheters.
Okay.
So this second one, yeah, as you can see, because it doesn't dip down as you would see an umbilical arterial catheter doing. So these were 2 umbilical venous catheters. And this second one is also too high up, and it's actually coiled within the right atrium. So that tip is within the right atrium.
Okay.
Yeah, as you said, the endotracheal tube is too far down, and it's in the right main bronchus. And you can see the lungs as well. What do you think of the lungs?
Yeah, I think there is increased opacifications on both sides. It might be due to the bronchial intubation of the endotracheal tube in the hindsight now. Yeah. And there is decreased aeration due to the bronchial intubation.
Yeah, so this patient, you can see there's bilateral diffuse kind of granular opacification of the lungs. And you can see some ear bronchograms as well. So the lungs are definitely abnormal, slightly of low volume as well. So this patient had respiratory distress syndrome, and you can see that all they've misplaced the umbilical venous catheters and the endotracheal tube. I'm not entirely sure what this line is. I think this was external. But yeah, so we've got 3 misplaced lines and abnormal lungs. So again, you need to, the next step would be to inform the team as soon as possible to let them know of the misplaced lines, and they will need to be replaced, or the ET tube will need to be brought back, withdrawn a couple of centimeters.
Okay.
And yeah, the abdomen, that was fine. You commented on that. So yep, no. Bowel gas pattern was normal, so there's no pneumoperitoneum. You can comment on portal venous gas or any mottling. Okay.
Yeah, so I've been provided with the frontal chest radiograph of a skeletally immature patient. This is a supine portable radiograph. I would like to quickly go through the sequence. Like the nasogastric tube is noted in correct position with the tip going through crossing the carina and going to beneath the left hemidiaphragm into the stomach. The other main thing is the endotracheal tube, which has gone beneath the level of the carina into the right main bronchus, causing the entire collapse of the left lung. There is complete opacification of the left lung because of the right bronchial intubation of the endotracheal tube. And apart from this, there are few externally lying tubes that are seen in the overlying the face, and there are no other tubes to be commented upon. Now going systematically through the airway. So this is bronchial intubation. There is complete opacification of the left lung. The right lung aeration is normal. There are no focal or any diffuse lesions. The costophrenic angle appears normal, and the bones show normal density, no focal lesions, no fractures. The visualized abdomen appears normal. There is no evidence of any pneumoperitoneum. So my principal diagnosis here being the right bronchial intubation causing complete collapse of the left lung. So in my routine practice, I will inform the referring clinician of the findings, as this is an emergency, inform the pediatric team for reposition of the endotracheal tube to the above the level of carina to promote aeration of the collapsed opacified left lung.
Yeah, very good. Yeah, so you spotted the findings. So you've got the ET tube in the right main bronchus and the left lung collapse resulting because of that. So good. So you commented on the lines and tubes first. So you've got the NG tube, which is appropriately cited, and the ET tube, which is obviously not. And you can see that there's volume loss on that left side. You can't really see the right heart border. You've got the gastric bubble, which is higher than usual, and that's because of the lung collapse and the hemidiaphragm being pulled upwards. You can see this rib crowding as well, which is suggesting that there's volume loss on that left side. So good, yep, you're going to call the team ASAP, inform them to withdraw the ET tube as soon as possible. Good. So yeah, this is just a diagram kind of explaining the different causes of an opaque hemithorax. So it can be due to a variety of things, and what you want to do is look to see whether there's any mediastinal shift, and that will help to figure out what pathology is causing it. So in cases of pneumonia, you won't necessarily get any mediastinal shift. When you're looking at the intercostal spaces, they will be symmetrical on both sides. You might get some delayed blunting of that costophrenic angle, which could be due to infection or pleural effusion. Yeah, so if you, so in other cases, if you get mediastinal shift, you want to see which side it's being pulled towards. So if it's contralateral to the side of the abnormality, so that could suggest an effusion or a large intrathoracic tumor. Other things would be a diaphragmatic hernia where you've got extra contents within the hemithorax. And you can look at the intercostal spaces, so they will commonly be widened when compared to the left side. You'll get, in the case of an effusion, you'll get early dense opacification of that costophrenic angle. In cases of collapse or post-pneumonectomy, you'll get ipsilateral mediastinal shift, and you'll get the opposite. So you'll get narrowing of the intercostal spaces, elevation of the hemidiaphragm because you've got low volume on that side. Other conditions that you can also get this type of appearance would be in pulmonary agenesis, aplasia or hypoplasia, and lymphangitis. So you'll get these narrowing of the intercostal spaces. So this is just something to keep in mind. So we'll move on to case 5. Yeah, so if you want to present this.
Yeah, I've been provided with a frontal chest radiograph of a skeletal immature patient. I would like to go systematically through the radiograph. I think there is the main positive findings. The important abnormality here is the complete opacification of the left hemithorax. With I think there is left hemithorax. There is elevation of the left hemidiaphragm, suggesting volume loss of the left hemithorax. I think there is decrease in the intercostal spaces when compared to the right side, again suggesting decrease in the volume of the left hemithorax. And I could not see the I could not see the cardia separately. The right heart border is also not seen separately. I think I could not right heart border. Yeah, I think there is no significant mediastinal shift onto the right side. The other important negative findings being there is no evidence of pneumothorax, and the right lung aeration appears normal, and going to the right hemidiaphragm appears normal. The stomach bubble is seen beneath the left hemidiaphragm. The visualized bones show no focal lesions or fractures. So the main interpretation being opaque left hemithorax with reduced left lung volume, and I think there is ipsilateral mediastinal shift, as we can see here. And my principal diagnosis will be any collapse might be due to an obstruction at the level of bronchus. Might be can I know the age of the patient? I think it is
So this was a chest X-ray done at birth. So this is day 1, yeah.
Day 1, yeah. I could not see the humeral epiphysis. I'm thinking of collapse in a neonate. Yeah, I think foreign bodies, all those things don't come into this age group. Might be some atresia, can be due to an atresia of the bronchus causing complete collapse of the left left lung. The other unlikely causes are foreign body, which doesn't occur at this age.
Yeah.
And I think I would go with atresia as my principal diagnosis, keeping the foreign body at the below the level of diagnosis being very unlikely. I will inform the referring clinician of the findings, inform the pediatric team of the findings.
Okay, good. Yeah, just a comment. So, can you see the airway at all, the bronchi?
Yeah, no, I couldn't actually really appreciate. Okay, I could see the trachea in the proximal part, but no, I couldn't appreciate much.
Yeah. Okay. So that was really good. Really good presentation. So yeah, you're right. So this was a chest X-ray at birth. So we're not really kind of thinking about kind of foreign body ingestion. But so this patient went on to have a CT, and so this we've got a single image, an axial image through the upper chest. So if you want to just comment on what you can see here.
Yeah, I've been provided with a single axial contrast enhanced CT image in lung window. Showing, I think there are multiple vascular structures in the medial and posterior, that is visceral and paravertebral compartments of the mediastinum on the right side. I think this is the heart. Yeah, I think the heart has fallen behind, and there is a single bronchus that is going on to the left side. The descending thoracic height appears normal. I think this looks more like an hyperexpanded right lung, and there is a complete collapse of the left lung. I think this is compensated hyperexpanded right lung, which is covering almost all of the thorax, and I think there is a complete collapse of the left lung. So I think this bronchus being only the right lung bronchus we are seeing here. And
yeah. Good, perfect. Well done. Yeah, so you're right. So this was, you're right. So this is hyperinflation of the right lung, which extends over onto the left side, and that's because this patient actually had left lung agenesis. So you can see that there's a complete absence of the left lung parenchyma. You can't really see it at all. You can't see the left main. I know this is just a single image, but there was no left main bronchus or vasculature associated because there was no left lung. So they had a single right main bronchus, and then the right lung has hypertrophy to fill in that space. So this was left lung agenesis. So you can get agenesis, aplasia, or hypoplasia. So agenesis being complete absence of the lung, the associated bronchus and the vasculature. Aplasia is where you get a blind ending rudimentary bronchus with the rest being absent. And then hypoplasia, you get rudimentary lung and bronchus, but then you get a decreased number of airways, alveoli and vessels that are associated with it. So it'll be much smaller hypoplastic. So this can be associated with other congenital malformations, especially in the case of congenital diaphragmatic hernia, where you have intra-abdominal contents in the thoracic cavity preventing that lung from developing normally. So good, well done. That was really good. Okay, I don't know. Are we moving on to candidate 2 now, or Azar, are you there?
Oh yeah, I'm there. Shall I present this case?
Yeah, go on. Okay.
Yeah, I've been provided with the frontal chest radiograph of a skeletally immature patient. The most striking abnormality being the complete opacification of the right hemithorax with contralateral tracheal and mediastinal shift. I couldn't see the right heart border separately. There is obscuration of the right costophrenic angle. And apart from this, the left lung, there is a decreased volume of the left lung due to the contralateral mediastinal shift. However, there are no focal or diffuse lesions within the left lung parenchyma, no pleural effusion on the left side, no pneumothorax on the left side. Apart from this, there is obscuration of the right hemidiaphragm. The left hemidiaphragm is seen clearly, and the visualized bones show no focal lesions or any fractures. So my principal diagnosis being complete opacified right hemithorax with contralateral mediastinal shift. So my principal diagnosis here will be a pleural effusion, which is causing a mediastinal shift rather than the collapse, which causes an ipsilateral mediastinal shift. So pleural effusion, large pleural effusion causing a contralateral mediastinal shift, or any mass which is causing a contralateral mediastinal shifts. So these are my principal diagnosis. I'll inform my findings to the referring clinician, inform the pediatric team for further discussion. I would like to do a cross-sectional imaging to know the exact cause of the this finding. I would like to compare with previous imaging.
Okay. Yep. So cross-sectional imaging. Is there? So what kind of modality would you want to do?
Yeah, I would like to do a CT thorax, low dose CT thorax, being a pediatric patient, to know exactly the cause, because my differentials here are a pleural effusion and a mass. I'm thinking of pleural effusion in the first top differential. So before I to proceed further and do any procedure or intervention, I would like to confirm my findings.
Okay, so in children, instead of doing a CT, what other
we can do an ultrasound. Yeah, we can do an ultrasound to know. Yeah, I would do an ultrasound first, and later we can go for cross-sectional imaging.
Yeah, so we can use ultrasound. It's easy, accessible, and we can assess the pleural spaces in children quite well. So so this patient went on to have an ultrasound, so we've got an image here.
Yeah, this is the transaxial image of the ultrasound of the same patient. I think the image in the right side being the liver, and there is a right hemidiaphragm, and there is pleural effusion with collapse of the lung. I think there is a fluid in the right hemithorax. I think this confirms my first differential diagnosis of pleural effusion being the cause of the opacification and causing the contralateral shift.
Okay, and do you think this is just a simple pleural collection, like simple pleural fluid?
I couldn't see any septa. There's a collapsed lung in it, but I couldn't see any septa or any loculi. I couldn't appreciate on this. Yeah, there is a. What do you think of this? I'm thinking that being a mass, and that being a mass or causing a reactive pleural effusion here. Yeah, I would like to.
Okay. So I'll just go through this. So I'll just go back to the chest. So you commented on all the findings. So you've got a pacification of the right hemithorax with mediastinal and shift and tracheal deviation. As you said, your differentials of pleural effusion or intrathoracic mass are correct, and then you'd go on to do an ultrasound to assess that further. So with this patient, you've got the liver here below, and then you've got this heterogeneous kind of pleural collection. So you've got this kind of tongue-shaped collection with no air bronchograms to suggest that it's a lung or that it's aerated, and that is something that we would see in consolidated lung. And you've got some fluid in the dependent area as well, which is evidenced by the low-level echoes here, and you can see the liver here, so you can compare the echogenicity. Obviously, this is seen better dynamically when you're performing the scan, because you can see the movement of the fluid echoes, and you can see the collapsed lung fluttering amidst the fluid as well. So this was an empyema, so it was a pleural collection, empyema. Good. So I'll just go through just the guidelines from the BTS on pleural on an empyema. So firstly, you want to take frontal radiographs and then do an ultrasound to confirm the presence of a pleural fluid collection. It's also done to guide the drain placement as well. And these guidelines basically kind of tell you when to do a CT. So for example, if the surgeons are considering a thoracotomy, or if you've got complex septations within the collection or echogenic collections, which are seen on ultrasound, that's when you would go on to do a CT. But yes, you're right. So the differential would be a mass as well, as you said. It's sometimes difficult to tell and confirm that on an ultrasound. Good. Okay, so we're going to move on to candidate 2. Thank you, candidate 1. You did really well.
Thank you very much. If no other candidate is there, I'll be happy to present again.
Oh, okay.
I'm candidate 2 here.
Yep, I can hear you. Hi, welcome. Do you want to present this case?
Sure. So, okay, this is a frontal radiograph, chest radiograph of a pediatric group patient. So, okay, I can see that the AETT tube is above the carina and is at the appropriate position. There are some other external lines as well. I think these are the electrocardio lines. There's another tube. I think it is external to the patient at the right upper neck until the hemithorax.
That's external. Yeah,
external. So other than that, okay. So I'm going through the airway. So airway seems central trachea, and I can see both bronchi and the lungs. Okay, there is homogeneous opacity over the right middle and lower zone, which are obscuring the right heart border as well as the right hemidiaphragm. So they might have some small right pleural effusion because of the blunting of the right costophrenic angle. So I don't see the right intercostal space seems still preserved. I think that the right lung volume is still preserved. Okay, so moving towards the left lung, the upper zone appears clear. However, there's some heterogeneous opacities over the left lower zone. I can't really see the left hemidiaphragm is not well outlined. Okay, so I'm reviewing at the bony thorax. It seems unremarkable. The heart appears still because it's supine, so I think it's still within normal limit. Okay, so I don't see any pneumothorax in this radiograph. So in conclusion, I think this is a clinically unwell patient which is intubated and showing bilateral lung infection, more prominent at the lower lobes, and also could affect bilateral lower lobes and also right middle lobe.
Yeah. Good. So you picked up all the findings. So you've got the ET tube, which is in a good position, and you've got this patchy airspace opacification within both lungs, mainly in the mid to lower zones. And the right heart border, both hemidiaphragms are obscured. So there's definitely some consolidation going on here, plus or minus pleural effusion. So this patient went on to have an ultrasound scan of both lungs. And what can you see here?
Okay. These are the selected images of ultrasound of this patient. For the left side, I can see there is hepatization of both visualized lower lobes. So I can see echogenicity within it could represent the air foci. I don't see any pleural effusion. So this confirms the findings of bilateral lung consolidation.
Yeah, good. So these images are demonstrating bilateral consolidation, as you rightly said, and this is, you've got hepatization. So consolidation on ultrasound, you get this hepatization and ear bronchograms of the lung. So you can see this echogenic branching structures, which are the ear bronchograms. And if you look at the echo texture of the lungs, it looks very similar to the liver, hence the term hepatization. So that was seen on both lungs in the previous images. And here on the right, you can see that there is also a trace, small pleural effusion as well, adjacent to that consolidated lung. Good. Well done. Okay, so this is just a slide just talking about normal lung ultrasound. So you're looking for A lines, which demonstrate the normal appearance of the lung surface. So what they basically are, you get these echogenic, kind of gradually fading horizontal lines below the pleura. And they basically represent the repetition artifact of the parietal pleura. And it just suggests that there's air beyond the pleura, which would be normal. And the distance is basically the same as the distance between the skin surface and the pleural line. Also, another point I did say that would suggest that it's normal, but you could also see these A lines in the cases of pneumothorax as well, because it basically just suggests that there's air beyond the pleural surface, and you'll get a similar appearance in that as well. It's better seen on a linear probe, but here you've got both appearances in the linear and curvilinear probe as well, where you get similar appearance. So that's the A line seen on normal lung ultrasound. Okay, so we'll move on to case 6. We'll continue actually.
So this is a frontal chest radiograph of an pediatric group patient. I can see that the airway is deviated to the right. Okay, and there's a total white out of the left hemithorax. I cannot appreciate any obvious left main bronchus. So the left heart border and the left hemidiaphragm are both obscured by this homogeneous opacity. Okay, and the intercostal space is still preserved over the left side. Okay, mediastinal shift to the right as well. The right lung is clear. The right hemidiaphragm is unremarkable. The bony thorax is unremarkable as well. So in conclusion, the left white out lung could most likely to represent left pleural effusion, massive pleural effusion causing the mass effect, causing right mediastinal shift. So my differential would be a lung mass, a left hemithorax mass causing this. So next step, I would convey this message to the referring physician, and I will proceed with ultrasound to confirm the finding.
Okay. So this was the ultrasound which was done.
So the ultrasound shows that there is presence of left pleural effusion, which confirm the finding, and also there is atelectasis of the left visualized lung. There is I think there's also a collapse of the lower portion of the left lung, which you see in the lower portion of this ultrasound instead of the mass.
Okay. Yeah, sorry. What did you describe this as?
Yeah, I mean, I'm not sure because I cannot see any bronchogram within it, a bronchogram. So I'm thinking it could be a total collapse of the lung lobe as well. Differential would be a mass. Maybe a dynamic ultrasound could help to see differentiate between these two.
Okay. Okay. Yeah. So we can see that this is the normal lung, and then you've got the anechoic fluid here, which is the pleural effusion. But then you've got this this extra bit here, which is quite heterogeneous and doesn't really have a similar echo texture to the lung that's adjacent to it. So this was a mass that was seen within the thoracic cavity, and you can see it's quite heterogeneous. There's kind of rounded cystic spaces which aren't really tubular, and then you've got these kind of curvilinear areas of high echogenicity as well, and it's quite rounded, well defined, and it's separate to the lung. So this was a mass, and this patient went on to have a CT scan to clarify that further. What can you see here?
Okay. So these are selected axial images of the left of the thorax. They are contrasted scan in the portovenous phase and the mediastinal window. So I can see that the presence of a huge mass in the left hemithorax, and it appears heterogeneous with some and also many other hypodense areas. I can see some calcifications within it. Okay, the lung, visualized left lung is atelectatic collapse, and there's presence of the mild effusion over the left hemithorax. It causes mass effect and pushing the mediastinal structure to the right. So in press, okay, and okay, this is a huge left lung mass.
Yeah.
So my differential diagnosis would be the left lung neoplasm. And okay, I forgot to mention about the bones. The visualized bones appears unremarkable. There's no.
Yeah, don't worry about them. Yeah, that's fine.
So differential would be left mediastinal mass, or most likely from the posterior or medial mediastinum. Yeah.
Okay. Good. So this CT is, you can see this large heterogeneous mass filling the left hemithorax, and you can see, as you said, the collapsed lung. You can see here with the air within the bronchi there, and it's causing contralateral mediastinal shift. And then there are areas of high density as well. So this was a contrast CT. So I think we've got some vascularity within it, and you can see there's they've inserted a drain as well, which you can see at the lateral aspect of the chest, extending medially. So this was a large mass. And you can see the low attenuation, which represented areas of necrosis centrally. So this was a pleuropulmonary blastoma. So these are quite rare, but most of them occur between the ages of 0 to 2 years old. And they have a lot of associations, particularly with CPAMs, other gene mutations, multilocular cystic nephromas, Wilms tumors, and they are classified into 3 types with an increasing order of malignant potential. So type 1, which has the best prognosis, is the cystic type. So we did see some areas, cystic areas on the ultrasound on that one, and then the type 2 is the mixed type, which is a slightly worse prognosis, and then the type 3 is the solid type. So these are usually right-sided, pleurally based. You don't tend to see much chest wall invasion or calcifications within them, but yeah, as we saw on the chest X-ray, they usually present with a whiteout of the lung with contralateral mediastinal shift. Sometimes they might be associated with the pneumothorax. And as we saw with the mixed solid cystic masses on the ultrasound, it usually presents with a heterogeneous mass, and sometimes you might also get a pleural effusion as well. So yeah, well done. That was a hard one, but you picked up that. You mentioned the right differential, so you're thinking about pleural effusion and intrathoracic mass, and you go on to clarify that further with doing an ultrasound of the chest.
Can everybody see my arrow moving? Can everybody hear me? Can you see a laser?
Move your arrow, Divya. Yeah. So we can see the laser pointer.
Yeah. Okay. Good.
Yeah.
And I hope my connection is clear, but please put in the chat if you can't hear me well, or if I break up.
I can hear you clearly.
Okay. Thank you. So just a brief introduction on what we are going to see in the next few cases. So we just saw a few cases which are based on whiteout of the lung, which is like a opaque hemithorax. And the next few cases are going to be about asymmetric lung densities. So as you know, normal lung, it would have air, and you should normally see it in a gray-black sort of appearance. It should not have any white or gray, like more white densities. But you can have asymmetric lung densities where the lung is having air, but there is still a bit of asymmetry. And that can be due to respiratory causes, especially when you have a contralateral mediastinal shift, and you see that there is an asymmetric density, that one lung is more hyperlucent, and you have a contralateral shift. And that can be due to foreign body aspiration. And this can look normal on a single inspiratory chest X-ray. So if the history is really suggestive, you need to be very careful and think about doing inspiratory, expiratory X-rays if the child can cooperate. Additionally, mucus plugging can also cause asymmetric lung density and air trapping. And usually these patients would have a background of asthma, or they would be on ventilation, and that leads to mucus formation and plugging inside the airways. You can also have congenital Lobar emphysema, which is a pediatric specific condition which causes asymmetric lung density and a hyperlucency. Or sometimes you can have tracheobronchial narrowing due to various reasons, which can lead to this. You can have respiratory causes without a mediastinal shift, and that is seen in causes of unilateral hypoplastic lung. One lung is usually having a lower volume, not a complete agenesis like we saw in the previous session, but it's just a lower volume, a hypoplastic lung. There is a condition which is called congenital veno-Lobar syndrome or scimitar syndrome, which is a hypoplastic lung which is associated with a partial anomalous pulmonary venous return. You can have constrictive bronchiolitis, which is also called Swire-James syndrome, where you can have a hypoplastic lung. There are cardiac causes which can cause asymmetric lung densities. It's not commonly seen in exams, but you can see it in post-cardiac surgery when you have had when the child has had a PT shunt, and very rarely in pediatrics you would have pulmonary embolism, but it does happen, and that would also lead to a hyperlucency of the lung. So what are the causes of tracheal bronchial narrowing or stenosis or compression? So you can have obstruction within the lumen, and that would mostly be foreign bodies, especially in toddlers. They would ingest or inhale or aspirate things. You can have mucus plugs. You can also have blood clots, and sometimes there are tubes which can get broken and occlude the airways as well. Within the wall, you can have abnormalities of atresia or stenosis. You can have tracheobronchial malacia, which is abnormality where the lumen collapses. And you can also have inflammation or fibrosis, which can cause narrowing. And tumors are rare in children, but you can have carcinoids. And outside the lumens, various causes of obstruction can be due to lymph nodes, or if they have congenital cysts or mediastinal tumors, which are compressing the mediastinal trachea, or you can have vascular rings or slings, which we'll also look at, and sometimes aneurysmal aorta, which is rare, but you can have aneurysmal aorta with some connective tissue diseases, or children with who have collagen vascular disease as well.
Divya.
So yeah.
Divya, sorry to disturb, but there's someone is annotating on the screen, so that yellow line. So are you able to switch off the annotations for everyone? It should be on the settings at the top, and it says kind of turn off annotations.
Disable annotations.
Yep, and then if we can remove that annotation as well.
How do I remove that?
Is there an option there to remove? I think that it says clear annotation. And then disable.
I've disabled the annotations.
Yeah, it's just there's that yellow line there, so we just need to get rid of that. Should be something that says clear annotation.
Oh yeah, clear all drawings. Yep. Is that?
Yeah, that's worked now. Great.
Cool. Mm-hmm. Yeah, sorry about that. Is it candidate 2 still? Do you want to present this one?
Okay, sure. Hi. This is a frontal chest radiograph of a pediatric group patient. So the airway is central. I can see both main bronchi clearly. The lungs, okay, I can appreciate some patchy opacities over the right lower zone, which are next to the right heart border. The right heart border is, however, still well demarcated, the right hemidiaphragm as well. There is some narrowing over the right intercostal spaces. And the heart is normal in size. And sorry, okay, I'll just continue with the lungs. So the lungs, I don't see any pneumothorax or pleural effusion. The left lung is clear. Okay, I'm going through my review areas: the apicals, the hilar regions, the retrocardia, the subdiaphragmatic spaces are clear. So the visualized bony thorax is unremarkable. So in conclusion, I would think this is right middle lobe opacities at the right in the right lung. So differential would be an infection. Yeah, I would correlate clinically, and if there's any previous radiograph to compare, maybe to do some comparison. So, yeah. So in conclusion, it's a right lung pneumonia involving the right middle lobe.
Okay, so that's good. That's well done, because you are saying the right lung is the abnormal one, and you are thinking that this is a possible consolidation.
Yes.
Okay. So can you see my laser pointer?
Yes.
So usually, when you can you appreciate a very subtle asymmetry between the lung densities, like a diffuse.
Yes.
Okay.
Quite subtle. Yeah.
It's very subtle. I agree with you. But so if I say this child presented with acute wheezing, would you like to do something further?
Okay, wheezing. So okay, so maybe okay, aspiratory.
Choking. Yeah. That's good. So now you can actually appreciate there's quite a asymmetry. You can describe that?
Yeah. So okay, So in the inspiratory radiograph, the lung densities appears quite symmetric, and relative to the left side, on the right side, the expiratory radiograph, the left lung is still preserved, is still relatively more loosened than the right lung, and the left lung volume is still more than the right lung. So in this case, I would suspect foreign body aspiration.
Yeah, correct. So in toddlers, the history can be very misleading. You would never see, sometimes they have not witnessed the child has eaten something, and probably it has gone into the trachea, and they're prone to picking up peanuts and stuff like that and putting that in their mouth. So you always have to worry when you have an audible wheeze in the history. And so you can clearly see between the inspiratory and expiratory, the left lung volume has not normally reduced. So in expiration, your lung volume would reduce, and the lung would become a bit more white when it's in expiration. So a normal expiratory lung, this is another pitfall of a expiratory lung radiograph. So if you have an expiratory lung radiograph, you are prone to see prominent perihilar markings. So you would tend to overcall them. So always be wary of an expiratory radiograph. And but in case of this, you can see there's a clear increased hyperlucency of the left lung on expiration because there is air trapping. So there's air which is coming into the left lung, but because of the foreign body which is lodged, there's like a one-way valve mechanism, and air is not able to get out. And that leads to like air trapping within the lung, and that leads to a hypertransradiancy of that side. So in this case, this was a foreign body, and in case of foreign body inhalation aspiration, this is an emergency. So you have to immediately call the referring clinician, and they have to go ahead with a bronchoscopy and remove the foreign body. And sometimes if it is clinically suspected, they wouldn't even wait for a chest x-ray, and they would just go ahead with a bronchoscopy and remove the foreign body. On chest x-ray, in advanced cases, you can have a complete lobar collapse, and but in cases where it's a partially occluding one and it's causing that sort of valve mechanism, it can lead to air trapping and thus differing lung radiolucencies. In the obstructed lung, as you saw, there would be no change in the volume, and the mediastinal shift, if it is air trapping which is causing a shift, it would be towards the contralateral side. And if there is a chronic wheeze or a recurrent persistent infection, a CT is better, because in case of partially occluding foreign bodies which are chronically present, they may not present with acutely, but they would present with recurrent persistent infections, and that is something that you would see on a CT. And remember, toddlers, they would commonly ingest, inhale, and you would not have a clear history. So if there is any suspicion, even clinically with an audible wheeze or a stridor or something, you would want to just go ahead with a bronchoscopy. So this is just a companion case, and this was a 2-year-old, and here you are able to appreciate it a bit better. So you can see that there is hyperlucency of the right hemithorax, and this was a child who was choking and was still wheezing, and they did the x-ray, and you can see how much there's a difference because of the air trapping. So next case. Is it candidate 2, or should we go to, is there a candidate 3?
No, we can move to candidate 4.
Yeah, sure. Candidate 4, if you would like to take this one. Hello?
If candidate 4 is not there, we could move back to candidate 1.
Yeah,
Are you still there?
Yeah.
Okay, so yeah, we'll go back to candidate 1 then.
Do you want to just present it how you would in a chest radiograph?
Yeah, I've been provided with a frontal chest radiograph of a skeletally immature patient. I would first discuss the tubes. The endotracheal tube is above the level of the carina. the nasogastric tube goes into below the level of left hemidiaphragm. I think there is one more overlying tube over the lower thoracic vertebra. Couldn't make out what it is. Now going systematically through the lungs, I could see in evidence of lucency in the right crostophrenic sulcus, and there is increased bronchovascular markings of the right lung. The right hemidiaphragm is seen clearly, and there is another lucency in the right paramediastinal region. Now coming to the left side, the left lung shows normal aeration, normal bronchovascular markings. Now coming to the cardia shows normal density. The left hemidiaphragm shows normal density. Now coming to the bones, there no evidence of focal lesions and fractures. So my main interpretation is the lucency noted in the right lower zone involving the right costophrenic angle, and another lucency in the right paramediastinal region. So may I know the clinical history of the patient?
This patient is ventilated in ICU, and this is a chest X-ray because he's developed new oxygen requirement, which is increasing his oxygen requirement.
Okay, yeah, I'm seeing here like there is increased granularity of the both lungs. I'm thinking in terms of a surfactant deficiency, and with the ventilation, I'm seeing like this might be either some small pockets of pneumothorax or pulmonary interstitial emphysema in the right lung and increased granularity. So this is my principal diagnosis, either pneumothorax or pulmonary interstitial emphysema. So I inform the findings to the referring clinician, inform the pediatric team, and compare with the previous radiograph to see the changes.
Yeah, excellent. That's really well done. And this is the same case over the next few days, if you want to describe.
I think same case. I think there is increase in the pneumothorax. I can see the lucency increase in the right upper zone. Again, there is that increased pulmonary interstitial emphysema of the right lung, and the granularity is still there in the left lung. I think the full-blown pneumothorax is seen in the right-sided radiograph, and they kept an intercostal drain tube for the same. I think the lines positions, there's no malposition of any of the lines. So I think this is a pneumothorax complicated due to pulmonary interstitial emphysema, which is a complication of ventilation of a surfactant deficiency disease.
Okay. The children who are on ventilation and with positive pressure ventilation, pneumothorax can happen even without an underlying lung disease. And in this case, I think it is related to their ventilation. But yes, it's very correctly identified on the first radiograph itself. It was a pneumothorax, and the clue there was the deep sulcus sign, as you said, along the right lower zone. And you have to be very careful in any patient with new pleuritic chest pain or unexplained breathlessness. Always look carefully for a pneumothorax, and always double check the lung epices as well as the costophrenic angles. And the three cardinal features, as you know, of a pneumothorax is when you have a clearly defined line, and that is the visceral pleura, which you can see in profile, and it will parallel the chest wall, and the upper part of the line would be curved at the lung apex. So that's why I always check the epices. The overlapping ribs can be a problem, so you should always make sure to go through each intercostal space and make sure that you look between the ribs, and if there's any absence of lung markings lateral to it, that is, there are no vessels, then you would suspect a pneumothorax. And you must always hunt for the evidence. Don't just briefly look at an X-ray, otherwise you will miss a small pneumothorax. But excellent, that was really well done on that case. And another case, if you just want to describe.
Yeah, I haven't provided.
Sorry, we just wanted to say candidate 4 was actually present, but we couldn't hear them.
Should we continue with this one, and then after the next case, I'll move to candidate 4? Yeah, okay.
Yeah, okay. I've been provided with a frontal chest radiograph of a skeletal immature patient. The most striking abnormality is the increased lucency of the left hemithorax. There is a pneumothorax with the collapsed lung, and apart from this, there is a continuous diaphragm sign which is above the level of the right and left hemidiaphragm, below the cardia, keeping in with a pneumomediastinum. I think patient has both pneumothorax and pneumomediastinum. There is no contralateral mediastinal shift. The right lung appears unremarkable. No pleural effusion, pneumothorax on the right side. There is no pneumoperitoneum. There are no focal lesions or fractures in the bone. So, principal diagnosis here being a left pneumothorax and a pneumomediastinum. I would inform the findings to the referring physician, urgently inform the pediatric team, and compare with the previous imaging.
Perfect. That's really well done. Additionally, in this case, there's also increased perihilar bronchial wall thickening, which you can really see well on the right side, although the left lung is collapsed because of the pneumothorax. So this is actually a case of viral triggered bronchiolitis, and in case of bronchiolitis, when it's severe, they can get pneumothorax and pneumomediastinum as well. So really well done. That's excellent. So candidate 4, are you able to present this case? Are you there? I can't.
Yeah, so they are unmuted, but we just can't hear them. So I think they might be having some technical issues. Yeah, because they're unmuted, but we can't hear anything. Okay, fine. We might just have to continue with candidate 1.
Oh, shall I continue or?
Yeah, you can. Feel free.
Yeah.
Sure. Yeah.
Yeah, I've been provided with frontal chest radiograph of a skeletally immature patient. The most striking abnormality is the air lucencies occupying the left hemithorax, which are going towards the right hemithorax and causing the contralateral mediastinal shift. I think I would go, and the other important finding is the nasogastric tube is going into the left hemithorax. The endotracheal tube is optimal in position. So these, and there is decreased, the massive decrease in the volume of the right lung. I could see the right hemidiaphragm. So to summarize my findings, cystic lucencies like pertaining to the bowel in the left hemithorax with non-visualization of the left diaphragm, contralateral mediastinal shift, and the coiling of the nasogastric tube, keeping in favor of congenital diaphragmatic hernia. So I would inform the findings to the referring clinician, inform the pediatric team, and I would compare with the antenatal and findings if there was there in the antenatal scan also, and compare with previous imaging.
Yeah. So you're right. This is a congenital diaphragmatic hernia, very well described, and usually they are picked up on antenatal imaging, and it is usually a postnatal X-ray which is done. But this is a CDH, and just to show another patient with the same diagnosis, and if you want to describe.
Yeah, I've been provided with frontal radiograph of an immature patient. The striking abnormality being the nasogastric tube going into the left hemithorax, no visualization of the left hemidiaphragm. There's continuity of the bowel loops going from the abdomen into the left hemithorax, causing contralateral mediastinal shift, and decreased right lung volume. And there is a pneumoperitoneum. I could see air beneath the right hemidiaphragm, and the visualized bones appear unremarkable, no fractures or any focal lesion. So my principal diagnosis being congenital diaphragmatic hernia with contralateral mediastinal shift and pneumoperitoneum. So I'll inform the findings to referring clinician, inform the pediatric team, and compare with previous imaging.
Okay, this child also has pneumothorax because they are on ventilation. So it's actually outlining here as well. So they are prone to have hypoplastic lungs, and that makes them more vulnerable when they're compressed to get pneumothorax, and then that would also track down into the peritoneum because of the hernia, and that's why you also have the air within the peritoneal cavity. But it's the lungs which are underdeveloped, which increases the risk of pneumothorax, and the air then enters the peritoneal cavity as well. So yeah, really well done. It's the same congenital diaphragmatic hernia, and usually they are left-sided, as you saw. They are Bocta-like hernias when they are left-sided, and the differential diagnosis would be a congenital pulmonary airway malformation because of the cystic appearance. And the treatment is usually surgical repair. Obviously, it is if it is possible in utero, they do it. But this helps in the management of pulmonary hypoplasia. And these patients, these children, babies, they often require ECMO support because the lungs are really hypoplastic, and usually they are not able to ventilate them sufficiently, and they end up being on ECMO support. The late onset hernias, they can also occur in group B stepped pneumonias, and if it is a right sided hernia, then you can have the herniation of the liver rather than the bowel loops. And fetal MR can confirm this diagnosis, especially when there is antenatal ultrasound and in equivocal cases. And fetal MR is now used to even quantify the lung volumes, and that helps in management to decide when to do the surgery, because they want the lungs to develop enough before doing the surgery. And these cases, they have significant mortality, and they're also associated with other system abnormalities, including neurological abnormalities, GI, GU, and cardiovascular abnormalities. So this is a very important condition to be aware of. So candidate 4, are you here now?
Yes, can you hear me?
Yeah, I can. Do you want to present?
So sorry for the previous. So the frontal radiograph of the skeletally immature patient now shows that the left hemithorax has got several lucences within, and the entire right hemithorax shows several lucences within, and there is a lung architectural distortion. I can see a radio density, small nodular radio density at the level of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10th vertebral pedicle. The trachea, visualized trachea appears normal. However, I cannot see the right bronchus. The cardia has almost occupied the entire left hemithorax, and the claustrophrenic angles on the both sides are normal. Based on the appearance, my differentials would be congenital pulmonary airway malformation and type 3, I would say. I would like to discuss this with the referring clinician and go for a cross-sectional imaging to check the diagnosis.
Perfect. That's really well done. What makes you say this is CPAM and nothing else?
I would have gone for a herniation of bowel contents had it been on left side and had seen a diaphragmatic discontinuity. Since the entire of hemithorax is basically not maintaining its normal architecture, I cannot think of any other differentials in this case.
Perfect, no worries. And what cross-sectional imaging would you do?
CT chest.
Just non-contrast?
Yeah. No, with contrast.
Okay, yeah, well done.
To see the vascularity too with the findings.
Yeah, no, really well done. So I'm giving you the selected CT images of the same patient.
Okay, so the cornal, sagittal, and axial reformat of the contrast-enhanced CT chest of the same patient now shows that I have got the same lucences here, and although there is a aplasia of the there is a hyperplasia of the left lung and ipsilateral mediastinal shift, and I am not able to make out the well-formed right pulmonary artery or the vascular supplies, although I can see some vessels there, and the bronchus Bronchial supply appears normal to me, but distally in the lung, I cannot see the well.
That's okay. You can
Aeration.
just describe what you see. That's fine.
So I see multiple variable size lucences, conglomerate lucences in the right hemithorax, and an underdeveloped vasculature to the to the right hemithorax. So again, my differentials would be CPAM.
Okay. No, that's good. The CT just confirms what you were suggesting on your on a radiograph. So there is like multiple cysts of different sizes, and you can see the largest cyst does look fairly big, and it's more than 2 centimeters. So this is just a congenital pulmonary airway malformation, and you would see on chest X-ray, as you said, you can see cysts with or without mediastinal shift, and depending on the size of the cyst, you would say whether what type of it is. Modified Stalker CPAM classification is used, and it is dependent. It is dependent on the size and the cyst. So the type 0 is incompatible with life, while 1 is the most commonest type, which is in more than 65% of the cases, and you would have large intercommunicating cysts, as we saw. And the type 2 has got the smaller size cysts up to 2 centimeters, and 3 is usually a solid lesion with very, very tiny cysts, and that type 3 will have a poor prognosis, while the 4 has got large cysts, and the type 4 CPAM is the one which can be a precursor of pleuropulmonary blastoma. And usually you do surgery for the large lesions, especially if they're causing mediastinal shift and are symptomatic, and they can be infected. So even if they are smaller but they have frequent infections, they would resect the lesion. And congenital pulmonary airway malformations, they are just early airway maldevelopment that leads to cystic and non-cystic lung changes. You have to be careful, they can be hybrid. So hybrid lesions are those who have additional features of sequestration. So they can have a systemic arterial supply along with the cystic spaces. So that's why we would always do a CT chest with contrast. And always make sure that when you do the CT chest with contrast, you extend up to the mid liver or edge of the liver, because you don't want to miss arterial supply, which sometimes can come from the celiac axis or from the SMA. So always do CT chest with contrast. And CPAMs, usually they are supplied from the pulmonary artery, and the drainage is to be pulmonary vein. There's not, they can communicate with airways, and that is the reason why they can get infected. So CT is always the modality of choice to further evaluate. So this is just showing the differences between the CPAM and the CDH. So as you said correctly, in the CPAM, if you see the dome of the diaphragm, you would not think of a CDH, while in a congenital diaphragmatic hernia, you would lose the normal ipsilateral diaphragm, and you would see multiple air-filled bowel loops which are occupying the left hemithorax. And mediastinal shift is much more seen with CDH, and CDH is also much more prone to cause lung hypoplasia, and that's why this is actually a much more difficult condition to treat and manage. Case 11.
Am I taking the case?
Yeah.
Oh, okay. So again, I am provided with the corneal reformation of the contrast enhanced CT chest of the skeletally immature patient and an axial section in the soft tissue window. In the left hemithorax, I can see differential prominence of the vasculature over the left diaphragm, I see an opacity with an arterial supply arising from the descending thoracic aorta, systemic arterial supply, and in the lower lung sections of the axial CT of the abdomen shows that the supply is from the aorta of the opacity. So based on the appearance, my differential would be sequestration. And I would like to discuss this case with the referring physician and report it to the consulting pediatrician for further management of the sequestration.
Yeah, perfect. Really well described. So this is actually just a pulmonary sequestration, and sequestration is a non-aerated lung lesion, and they are commonly seen in the left lower lobe, and they have arterial supply. So in this case, you can see the systemic arterial supply is from the supradiaphragmatic aorta here, and in this case, there was venous supply to the azygos via a tortuous vein. So the drainage was also to a systemic venous system. Sequestration is just a mass of lung tissue which gets disconnected from the bronchial tree and then derives the blood supply from systemic vessels. It looks very much like a collapsed lung in terms of the enhancement, but you would definitely have to look for the systemic arterial supply. There are two types, intralobar, which is more common, and that would have a pulmonary venous drainage, and extralobar, where you would have a systemic venous drainage to the azygos or portal venous systems. The chest X-ray will be very difficult to pick up, or they can appear normal because the opacity is usually basal, and on ultrasound they look like homogeneous hyperechoic masses, and you can sometimes see a feeding artery on ultrasound as well. These abnormalities can also be picked up antenatally on ultrasound and subsequently on fetal MRs, but CT remains the most sensitive modality to evaluate the small feeding vessels and arteries. So that's why that's the modality of choice. And just to show the example of the hybrid lesion that I mentioned earlier, you can have a cystic pulmonary airway malformation, and that can also have arterial supply here, which you can see from the celiac axis with pulmonary venous drainage into the pulmonary veins. So this is the reason why you always have to image lower down until the at least till the L2 vertebral level. So you include the abdominal aorta because you can have systemic supply even from the branches of the aorta. Candidate 4, do you want to go ahead with this one as well?
Yeah, please. So the frontal radiograph of the skeletally immature patient shows a well-positioned nasogastric tube and few outside oxygen, few leads on the outside. And on the right hemithorax, I see irregular lucency occupying the right mid and lower zones, and but I can see the vessels through them, and the costophrenic angles, cardiophrenic angles appear normal. The aortic silhouette appears normal. Based on the appearance, my differentials would be of an air trapping in the form of Lobar emphysema, or the differentials of I do not see any vascular abnormality to say is there any scimitar syndrome, but I'll put my differential of congenital lobar overinflation, or it could be due to post-infectious bronchiolitis, it could be Swyer-James. I would like to discuss with the referring clinician, and if possible, go for a cross-sectional imaging.
No, you would definitely go for cross-sectional imaging. That's really well described. But do you think this lung on the left, whether it's increased volume or
on the left lung, I see some tube coming from outside. Is there a drainage tube on the left side? I can see deep sulcus sign.
No. On the right side, you described it perfectly. But do you think that is increased volume, or like you mentioned that your other differentials were Swyer-James, like post-operative bronchiolitis? But do you think that is increased volume, or does that look like hypoplastic, or?
It looks to me of an increased volume.
Yeah. So do you want to look at the CT and then?
Yeah, please. Okay, so contrast enhanced CT chest sections in the lung window in the I guess see on the right side there is an opacity on the right side with a vascular supply to it from the I'm having a hard time to describe that finding. Definitely, there is an increased volume of the right hemithorax, and
Yep.
yeah.
No, that's absolutely right. I'll just describe this again for you. So on this radiograph, this is a 3-week-old baby, and you can see that there is lucency and paucity of bronchovascular markings with hyperexpansion in the right mid-lower zone. So the thing that you were thinking was congenital lobar overinflation, which is actually one of the main differentials here. And always remember that when there is an asymmetric lung density, the lung which has got a paucity of vascular markings is the abnormal lung. So when you look at the CT, you can see that the hyperinflation of the right middle lobe is there, and you can see there's a paucity of lung markings when you compare it to the normal left lung. So in asymmetric densities, look for the vascular markings, and if there's a paucity of vascular markings, that's where your money lies. That's where the abnormal lung is. So this is a congenital lobar overinflation, as you said, and it is involving the right middle lobe, which is hyperexpanded. And additional findings are just there is dependent atelectasis in the right upper and lower lobes, but that is probably related to them having the scan under GA and having the ET tube in. So congenital lobar emphysema is again, the differentials would be CPAM, but CPAM would be more cystic, and the differential which is very difficult is a bronchial atresia. Because you would expect a similar sort of a segmental or lobar hyperinflation when you have bronchial atresia, but in bronchial atresia you would see the blind ending of the atretic bronchus, and there are no features of this on the X-ray or CT. And this case also had additional absent pulmonary valve syndrome. And in congenital lobar emphysema, it is mainly a bronchial abnormality, and that leads to lumen obstruction, and this leads to a sort of a check valve mechanism, just like how it happens in a foreign body. So you get progressive hyperinflation of that affected lobe, and you would see this as a hyperlucency and overexpansion, as we saw on the chest X-ray, and that may cause a mediastinal shift. And it most commonly affects the left upper lobe, followed by the right middle lobe, like we saw in this case. And the treatment is surgical lobectomy, as these patients, they can develop a respiratory distress. So case 13.
Yeah, again, the frontal radiograph of skeletally immature patient shows well-positioned nasogastric tube and a mediastinal shift towards left due to a hyper expanded right hemithorax, where I can see differential lucencies and opacities. The lucencies have got it looks to me as it's not bowel. I cannot demarcate the diaphragmatic outline. There is a component of effusion with air in the right hemithorax. And also the right bronchus is narrowed than as compared to left. I would like to.
Yeah, what would you like to know?
I'd like to perform a contrast enhanced CT test of the patient, if possible.
Okay. Would you not want to know why they have presented, or what the history is, just so that you can justify your CT?
Yeah.
Sure. So this child is 13 months old, unwell for 3 weeks, has cough and fever, and reduced air entry on the right chest. And the question on the thing was query congenital diaphragmatic hernia, but with that history of cough and fever, do you still think it's CDH or?
The lucences appeared to me in the first impression as that of bowel, but I do not see the communication of the bowel loops with that of the abdominal contents, and even the NGT tube is positioned well. So there lies the dilemma between like to designate it as a CDH or not.
Correct.
First impression was for a CDH only.
Okay, so you would like to do a CT with contrast?
Yeah.
So this is limited axial CT, and then I also have coronal in soft tissue. And let me know if you want to go back.
So the coronal shows that it is definitely not CDH, and I can see the diaphragmatic outline well, and probably the lever with the vascular markings. What I can see now is that there is a large opacity and effusion with internal air lucences within. And I can see the collapsed right lung in the hilar region. And the vascular supply to the lung and the bronchus are not that well defined. So it's basically then there's atelectasis in the left lung. I'm not able to reach to a differential based on the appearance. Is it bronchial atresia?
Okay, if this was an adult patient, what would you think? With cough and fever.
Infection leading to hydropneumothorax, buildup of with consolidation showing cavitation within.
Yes, so this is actually necrotizing pneumonia with cavitation. And if you see on the contrast enhanced CT, this is actually, my laser is not moving, unfortunately. But there's enhancement of the pleura. So this is actually like an infected pleural collection, and the lung, as you rightly said, part of it is collapsed, which you can see is well enhancing along the right lower lobe. And but the whole of the upper lobe has formed a cavitation, and you can see a air fluid level within that cavity. So this is cavitating necrotizing pneumonia, and a bronchopleural fistula is a very it can occur as a complication for necrotizing pneumonia in children, and they would require urgent pediatric cardiothoracic input because they have increased morbidity, and usually they have thoracotomy to get all the infection out. And when you're evaluating effusion on ultrasound, as previously described, you have to make sure whether you think it is a simple effusion, which is just anechoic, versus an empyema, where you would have loculation, septations, echoes. And always in CT, you have to look for the lung enhancement in complicated cases. If there's reduced lung enhancement, you have to highlight that there can be lung necrosis, and that predisposes to them developing the cavitation. And this is mostly seen with staphylococcal and Klebsiella infections, but rarely we see them with group B streptococcal infections and TB as well, just like in adults. And there's this another case for you just to see that there is a cavity within the lung, and you can see the loculated pleural.
Divya, I'm sorry to interrupt. Divya, I'm sorry to interrupt. Can you point out the findings on the imaging, because some of them
I'm
can't
not
see
able
what
to
you mean.
move the laser. Sorry, it's stuck there. Hang on. Bear with me. Sorry, Toby. My laser pointer has stuck. Okay, now can you see it?
Yeah, I can see it now.
Okay, let me go back to. Okay. So this is the collapsed right lung, which was well enhancing, as you saw, and there's no area of necrosis within this one. But if you see this lung, there's this big cavity, and you can see an air fluid level within the cavity, and you can also see these loculated pleural effusion that is seen along the costal pleura here on the left and along the mediastinal pleura. And on the sagittal view, you can see it really well, the loculations, and the lung adjacent to it is tethered along that. Here you can see how the collapsed lung is enhancing here like a tongue, but you can't see enhancement of the lung here. So all this is concerning for further necrosis. So this is a case of necrotizing pneumonia. This child had chickenpox 2 weeks ago, and the source of infection was group B streptococcus, which sometimes enters through the skin when the pustules are breaking, and then it goes through hematogenously and causes lung infection. So another case where this is a case where you can see that they have developed a bronchopleural fistula. So again, the lung is not enhancing, and there are areas of cavitation within, and there's a pneumothorax where they have put a drain in. So these cases are very much prone to develop bronchopleural fistula. So always look for lung enhancement on CT. Just as you would in the liver, if there's non-enhancement, then you are concerned about necrosis. So case 14.
Yeah, so frontal radiograph of the skeletally immature patient shows a prominent soft tissue along the right paratracheal region and right hilar region, suggesting vascular origin of the opacity, giving the cardiac silhouette a definite appearance of I won't say it's a figure of 8 or something. Speaking of the lung fields appear normal to me, and the costophrenic angles and bones appear normal. Trachea, vertebra, normal. So this my differentials on the appearances on this appearance would be of Scimitar syndrome. Although I cannot see the Turkish sword appearance of the pulmonary artery.
Okay.
Or it could be, yeah.
What was your concern again? Sorry.
The Turkish sword appearance of the pulmonary artery.
So you are mentioning this, right? Is this what you are looking at and describing?
I'm more concerned of the right paratracheal region opacity as it of thymus origin or vascular origin.
Okay, so you're thinking it's this, right? Am I pointing it correctly? This.
Yes.
Okay. So you're correct. This is actually the thymus, but given the age, this is normal as expected. And they are really rotated, so that's why it's projecting more towards the right.
Yeah.
But there is, in fact, this is actually a radiograph which is normal. There's nothing which is jumping out in this one. But let me give you the history. This child has had an antenatal lung abnormality, and that's why they got the X-ray postnatal. Would you want to do something further?
Again, a contrast enhanced CT chest so that I could get a brief insight into the vascular airway and the overall lung architecture.
Yeah. So they went on and had a CT, and I'll just scroll through it for you. I hope it is scrolling. Sorry. Okay.
So along the right paracardial region, I can see an opacity of the abutting the lung, abutting the pericardium, and air trapping in the left lower lobe, and some subpleural atelectasis in left upper lobe. And so again, a lobar inflation in the left lower lobe. And can I see that opacity of the right pericardial region? What about the bronchus?
Yeah, sorry, it's just loading. But I agree with you. There is left lower zone lucency, and there's paucity of lung markings of vascular markings in that region. So that is where your abnormality lies. The soft tissue which is seen along the right, it's just normal thymus. So I would not really be concerned about that. But the finding here of note on the CT is that there is the hyperlucency, which represents air trapping with reduced vascular markings. And the bronchus, you can trace it down almost up to the segment level, but then there is Sorry, it's slow. Let me just. So that soft tissue that you're seeing along the pericardium, that's just normal thymus. So I would not really focus much on that. And given the age, that is within their physiological thymic size. And the rest of the lungs are normal. So you gave the differential of
congenital lobar overinflation, or it could be post-infectious bronchiolitis. Has said that it had a history of antenatal presence of the condition. So,
yeah.
So James.
So actually, because this is antenatal, you would focus towards something that is like atresia or overinflation. So this is a case of actually bronchial atresia. Let me just go on to the next slide if I can. It's for some reason it's stuck here. So just scrolling down again, you would be able to see the bronchial atresia, because that is
yes. Left lower bronchus could not be tracked till the air trapping. Yes.
And distal to that distal to that bronchial ending, you can see that that segment is the one that is involved, and that is the one that is hyperinflated. So just a brief thing about bronchial atresia is that the air enters the affected lobe, and again through collateral channels it would cause hyperinflation, but because of the air trapping, you would see that hyperinflation. And differentials again would be congenital lobar overinflation, congenital pulmonary airway malformation, intralobar sequestration, and sometimes in ABPA you would see a finger in glove appearance of bronchial of a mucocele. CT is the best study again to assess for the bronchial atresia, and you must exclude a central obstructing neoplasm. Sometimes that is the cause of the overinflation, and in older children, adults, it is usually asymptomatic and can be incidental findings, and in younger children it can be a cause for recurrent infections, or cough and SOBNVs can be some of the presenting findings. So this is just another chest x-ray which shows the finding of the bronchial atresia. So you can see this sort of perihilar opacity, which is of soft tissue density, and distal to that bronchial atresia you see the overinflation that is involving the left upper zone. So if you see a hyperlucent lung with paucity of the bronchovascular markings, that is the one that is abnormal, and the rest of it is the normal lung. So this is bronchial atresia. So case 15, does candidate 1 or 2 want to have another?
Yeah, I'm.
Can I go for it?
Yeah, candidate 2, please. Yeah, go ahead.
Yeah, this frontal radiograph for a pediatric group patient is a frontal chest radiograph. So there is hyperinflation over the left lung, and with hyperlucency over the left lung as well. So I think the abnormality lies in the left lung. The right lung relatively appears clear. There's no nodules or consolidation. There is widening of the left intercostal space also. So there's an ill-defined cystic lucency over the left upper to mid zone, with a thin wall. With thin wall. And the pulmonary vasculature still can be seen superimposed at this region. So, okay. In conclusion, I would suspect my primary diagnosis would be left lung cystic lesion, CPAM, and also if there's previous infection, this could be a pneumothorax. Yeah, and it could be due to lung cavity as well. So yeah, I will review the previous radiograph and to get further history from the referring physician.
Okay, good, very good. The history is antenatal lung abnormality.
So if it's detected antenatally, so I would suspect this is a CPAM. So CT chest could be helpful to differentiate this with the hybrid lesion.
Perfect. So this is your CT chest.
Okay, yeah. The selected images of the CT thorax in both mediastinal and lung window. This is a contrast study. I can see that there's cystic lesion at the left upper zone, and which I don't see any communication with the bronchial tree, and I did select the images and I don't see any systemic supply, arterial or pulmonary drainage, or the venous drainage to this lesion. There is also a hypodense lesion over the mediastinal region, which is next to the coronal. Yeah, there's the lesion. So still, I will review the rest of the imaging to see whether there's connection to the bronchial tree, and if there is, I would suspect the cystic lesion could be a CPAM. And regarding the hypodense lesion at the mediastinal region, my differential diagnosis would be a soft tissue lesion. Most likely it's a lymph node. And review other images of the CT scan to see check the position of the mediastinal, whether it's in the middle hilar or it's at the posterior mediastinal region. So to give my further differential diagnosis. Yes.
Okay. No, that's well done. You didn't give up on one abnormality. That's really good. So this is actually in the middle mediastinum. You can see it clearly. It's in the subcarinal. So it's playing the bronchi, and it's actually a cystic lesion. I know it's not really well projected, but here you can see it's fluid attenuation. So this is actually a bronchogenic cyst. 85% of them are there in the mediastinum, 10 to 15% they can be within the lung, usually within the proximal third. And you have to differentiate them from enteric duplication cysts, which might be difficult, or pleuropericardial cysts. They can communicate with the tracheobronchial tree, so well done. It was not, and CT is the best to evaluate the relationship with the adjacent structures and look at the content of the cyst. They can be associated with congenital malformations, as in this case with CPAMs and others. And often bronchogenic cysts are asymptomatic and they are picked up incidentally, but they can sometimes cause compression on the surrounding structures or become infected and cause repeated pneumonias. So just to summarize, congenital thoracic malformations, they are usually diagnosed antenatally, like in most cases, especially if they are large and have a lot of cystic spaces. Fetal ultrasound is very good for initial diagnosis, and fetal MR is used to assess the lung volumes and to plan for intervention. Postnatally, the chest x-rays, as we saw, are not very sensitive or not very specific as well, and CT with contrast would be your gold standard to assess the lesion, the rest of the lung parenchyma, the vascular supply. And I would say try to establish that this is congenital thoracic malformation rather than try and get to exactly what it is, because you would always need to do a CT to exactly delineate everything. But you need to make sure that you don't miss a CDH, because that is an important condition and it's difficult to manage. Make sure you don't miss out on infections like we saw necrotizing pneumonias, and tumors like cystic tumors like pleuropulmonary blastomas or teratomas or neuroblastomas. So approach the lung structure systematically. Even on CT, you need to trace the tracheobronchial tree, trace the vascular supply, the fissural anatomy. Look for the internal characteristics. Are there cysts? What is the size of the cysts? Is there any mass effect or heterogeneity? And always keep your descriptions radiological and do not try to go into the pathology of it. Keep the clinical history in mind and try to make sure that you narrow your differentials to the most probable top 3 or like that. So there's a break, but I'm not sure if we can see all the cases after this. So let me just do a Q&A.
Yeah, we're meant to finish at 9, so I thought we'd just go to the questions.
Yeah.
So I will start reading them out. Give me 2 seconds. So back to case 7, which I think was a case with a pneumothorax. So the question is, the person that was asking the question thought that they could see vascular markings on the chest X-ray laterally on the right side. Can you just put the X-ray back up, please?
Sorry, Toby, this CT doesn't move. Yeah, I mean, it was actually a supine film. So you have the key in that one was the deep sulcus sign, which was the main finding. So in supine films, you may not really see your the clear pleural line, and but you would definitely be suspicious if you see a deep sulcus sign, which was really well identified by the candidate. So that was the main thing while I wait for the CT2.
Okay.
So,
We'll come back to case 7 because there's another question asking to show the deep sulcus sign, but we'll wait for the CT to behave itself. And then on case, oh wait, that's another one where you have to show. There's a question about do you know why group B streptococcal pneumonia patients are more prone to getting diaphragmatic hernias?
yeah, they cause necrotizing pneumonia. So they are necrotizing and cavitating, and I think that's the reason why they're aggressive.
Yeah. Okay.
But not otherwise not anything particularly that leads to CDH.
It's just that they will affect the diaphragm because of all the inflammatory stuff.
Yeah, and it would be a late it's more in late older age children rather than
the congenital diaphragmatic hernias.
Than the congenital ones. Yeah.
Okay, perfect. Okay, and then the next question is, this is just a clarification. Does lung hypoplasia lead to increased or reduced lung density?
Lung hypoplasia.
Yeah.
So lung hypoplasia, it can have a normal density, honestly. If it is agenesis or if it is a collapsed lung, you would have high density, but just hypoplastic lung would probably appear normal density. I don't think it would appear as high or low. Obliterative bronchiolitis, on the other hand, might appear a bit more lucent.
Yeah, okay. I agree. I think the density is normally normal unless there's some superadded infection or some atelectasis. But I think the density is normally normal.
It's a smaller size, not
it's just a smaller volume of lung rather than anything else. Okay. Is it scrolling at all now? Because some questions are about specific cases. Okay. So
I've got
okay,
that.
perfect. So if we go to case 7, and if we just show the deep sulcus sign for the people in the audience, that'd be great.
Okay, it's gone all the way to the top now. Hang on.
Oh yeah, you were there. You were just there.
Case 7.
7. Yeah, I think.
Yeah. So this is actually this was the 8 actually. You wanted the 7. Sorry.
Oh yeah, sorry, case 8. Sorry, I got my cases wrong. Yeah. No, it's case 8. I think the one with the deep sulcus.
Yeah, it's this one. Yeah. So yeah, this is actually the sign which was picked up really well by the candidate. So pneumothorax it's tough, and usually in supine films, especially when there are ventilation, there would be a supine portable film. You are not going to see the air rise up to the apex, and this is something that you have to be very, very always look and make sure you don't miss this.
Okay, and then case 9, someone's asked about were there lucencies over the right shoulder. I don't remember seeing them, but
9.
on case 9, yeah, they've said are there lucencies on the over the right shoulder, but I think that might just be soft tissue composite shadowing.
Yeah. Oh, you mean probably the
okay.
next one,
And then
this one.
Oh yeah, that one. Yeah, maybe. Oh yeah, there, just in the above the clavicle.
I think it's something that is superimposed because there's a whole big. I think it's something external. It's not. It doesn't seem to be within the patient.
Yeah, it looks like it's external artifact.
Yeah.
Okay, and then they said, could you please mark the pneumothorax in the second on that case? Can you just show where the pneumothorax is, please?
Sorry, I actually. Can you just see this lucency here, and then there's a line between the rib?
We can't see your pointer. It's gone.
Oh, okay. Can you see it zoomed? I zoomed it a bit.
Yeah, we zoomed. Yeah, we can see it zoomed. Yeah.
So here, if you just see my when I go back to my pointer, but if you can see along this rib intercostal region, and now if I zoom it, you can see this sort of line which is along the thing, along the thorax.
Yeah.
So that is where the pneumothorax has happened, and then it's tracking through the hernia along into the peritoneal cavity. So that's the diaphragmatic hernia with pneumothorax.
Okay, perfect. Thank you very much. And then, sorry, let me go back to my questions. The next question is on case 12. Why were the lung lobes atelectatic on the right side along with the area of overinflation?
Case 9.
Why was there areas? No, 12. Why were there areas of atelectasis with the overinflation?
So usually these children, they have CT scans under GA sometimes, and when they have ET tubes in and they're under GA and sedation, they would have these atelectasis, dependent atelectasis. So, and this child also had the background of absent pulmonary valve syndrome, so they have had other they would have had interventions, and that also would lead to atelectasis.
Oh yeah, so okay, so it's a bit of chronic and a bit related to the general anaesthetic. Perfect.
Yeah.
And then how to differentiate hypodensity in lung as to whether it's from necrosis or trapped secretions in a pneumonia. It's a question. I feel like they look very different. So to differentiate hypodensity in the lung is or because of trapped secretions in a pneumonia. But I think secretions are normally hyperdense rather than hypodense.
Yeah. If it's in a bronchus, you mean in a bronchocele?
Yeah.
They would, and bronchus is if the secretions are within a bronchus, it would be branching. So you would see them like fluid filled branching within the lungs. But if the lung is not enhancing, like in this case, you would see it as a more like a blob. Or non-enhancing along the lung margins, and in chronic cases of bronchial mucus secretions, you would get them as hyperdense, as in case of AGPAs or.
Mm-hmm. Okay, and do you have any specific windows you use to look to assess for necrosis or hypoenhancement of the lung parenchyma?
So if you just look at the mediastinal or soft tissue window, for example, here you can see the lung enhancement here, but you cannot see it enhancing here anteriorly along the right lower lobe. So the normal collapsed lung would enhance, as in here, but the abnormal areas which are getting necrosed would not.
Okay, I think when you zoom in, we lose your pointer. So do you mind zooming out a little bit, and then we can see your pointer to see the different areas?
So here is the normal enhancing. You can if you correlate it with the sort of a tongue shape, and you can see this enhancement. But here is the anterior bit. So if I zoom it now, the anterior bit doesn't enhance as well as you would see in a normal lung collapse.
Thank you very much. And then couple more questions. How can we differentiate congenital lobar emphysema from bronchial atresia?
That is a very difficult differential. I really admit to that. And you really need a CT stack to make sure. For example, this was the case of bronchial atresia, and I apologize for the painful, slow scrolling of the scan. But so in bronchial atresia, you would have the segmental, usually the segmental or subsegmental bronchus is affected. And when you see, sorry. So the area that becomes hyperinflated is distal to that atretic bronchus. In congenital lobar emphysema, it would be affecting a whole lobe. So for example, here it's the whole of the right middle lobe, and you don't really have that blind ending sort of bronchus, which is distal to which you would see it. So I think that is the main differentiating factor that I see. And other thing is the location. So this would be in the right middle lobe and right up and lower left upper lobe. That would be a segmental sort of affection, not a whole lobe.
Yep. Not as a whole lobe. Okay, thank you. So those are most of the questions. There are a couple, but I think you've answered them as you did the talk, so I've kind of skipped those. Are there any of the cardiac cases that you think are worth just showing without doing it Viva style? Any out of the ones that are left? Any good examples? Because we've got about 10 minutes.
I'll just briefly show some of the other chest cases rather than, because the cardiac would take a while.
Okay, fine. Yeah. So if there's any other cases,
yeah,
that'd be good.
I'll try and get past this CT again. I am really, really sorry about this. But main points which I wanted to say was in asymmetric lung densities, the area of lucency with paucity of pulmonary vascular markings, for example, here, as we just saw, that would be the area which is the abnormal one. So even on the X-ray, you have to look for the hyperlucency with paucity of lung markings. That is the abnormal one. So this is just a case of, again, I would let the CT scroll by and show you the static images. But you can see there is bronchiectasis bilaterally and the bronchial wall thickening. And in a child, when you see bilateral bronchiectasis, the most common differentials you should have is cystic fibrosis. And so this is just another patient who has cystic fibrosis. So you would see radiating bronchial wall thickening from the hila towards the periphery. And these patients would have a central line-in because they are usually treated with long-term antibiotic treatment. So this is when they present with acute exacerbations. You can see there's bronchiectasis, tubular markings. You can see them as a linear or rounded lucencies with wall thickening. So cystic fibrosis is a common condition which has bilateral bronchiectasis in children. And it affects the middle and the upper lobes predominantly. You would have the tubular markings and then finger in glove sign. So always think about it. And if you see a multisystemic, this is a multisystemic disorder, so you would have to look at involvement of other organs like pancreas. In liver, it can cause biliary cirrhosis, fibrosis. Look at paranasal sinuses for mucosal thickening. So on CT, you would have bronchiectasis, and the differentials for cystic fibrosis or bronchiectasis, you can have bronchiectasis with primary immunodeficiency, or you can see them in obliterative bronchiolitis or in post-infection, especially after infections like TB. So, and cystic fibrosis, usually they would have screening at birth if the family history is positive. So they would get sweat chloride test and other lab markers to make sure when they are, if they have a positive family history. So that is cystic fibrosis. And this is a case of, you can see this focal opacity in the right upper zone here, and this is a case of round pneumonia. So in young children, especially less than 8 years age, you can have round pneumonias because the collateral ventilation is not really well developed, and the exudates would then accumulate in that in those alveoli, and they cannot use the collateral ventilation pathways to diffuse and form like a lobar pneumonia, so as they would in an adult. So that's why they form a sort of a rounded sort of a shape, and be careful about them because they can be misread as a focal mass, and it sometimes there's a mass and you can think this is a round pneumonia. So if there's any clinical discrepancy, it doesn't if clinically they are not suspecting infection, it might be worthwhile getting a follow-up x-ray just to look for resolution. And Streptococcus pneumonia cause more than 90% of these round pneumonias. You can also have bilateral multiple nodular opacities in children as well, and again metastasis is a differential. So in children there's a very good differential in Chapman if you just want to have a look, but if the nodules are more than 5 millimeters in size and you're thinking neoplastic in children, the common differentials would be Wilms, Ewings, neuroblastoma and osteosarcoma, and again Mets would be more common in the lower lobe and peripheral. You can have infections like staph, abscesses, septic emboli, or fungal infection in immunocompromised patients. So always ask about the history in these cases. Then I just have a couple of pneumomediastinum cases. You can see the continuous diaphragm sign and air along the aorta. Just briefly, this is a case who was on ventilation, had COVID pneumonia, and developed severe pneumomediastinum, pneumothoraces, as well as pneumoperitoneum. So that is just showing all the findings. Case 20, this is a really interesting case, but the key finding is this. So you have a right-sided aortic arch. Although the patient is rotated, you can see that this is more prominent. And in this case, this is an older child, so you would not really think of a thymus. A thymus would be this big only up to the age of maybe 5. But in an older child, if you can't see aortic knuckle on the left and on the right, you have to suspect the right aortic arch. This child had dysphagia, so they had a barium swallow, and you can see that there is narrowing in the upper esophagus here with posterior indentation. So you're thinking about external compression, and that could be a vascular ring. So if you have a right aortic arch and aberrant left subclavian, that is an obstructing anomaly. The other differential would be a double aortic arch, which would also be obstructing abnormality and can cause dysphagia or tracheal narrowing. So this is just the CT of that patient, and you can see there's a right arch. So when the aorta is to the right of the trachea, it is a right arch. If it is to the left, it's a normal left arch. And you can see the aberrant left subclavian there. And this is a case of the double aortic arch, where it is going on both sides. And you can see the 4-vessel sign because both the carotids and the subclavians would arise together from the respective arches. So just a brief on vascular ring and sling. So ring would be complete encircling of the trachea and esophagus, while a sling is when an anomalous LPA arises from the RPA. And if there is a stridor, you should always think of double aortic arch or an obstructing ring. And pulmonary, if there is no right aortic arch, then you have to consider a sling. And just to show the sling, it is like aberrant left pulmonary artery arising from the from the right pulmonary artery, and it would go behind the trachea, and this will go between the trachea and the esophagus. So this sling is the only vascular aberrant vessel that will go anterior to the trachea. All the others would be anterior to the esophagus. All the others would be posterior to the esophagus on a swallow. So a sling is the only abnormal one which will go anterior to the esophagus. And this is a case of H-shaped tracheoesophageal fistula. So you can see that on swallow, positive oral contrast, you can see that there is opacification of the trachea as well as the esophagus. And you can see this very, very slender sort of a tracking of the contrast anteriorly. So this is a H type of tracheoesophageal fistula. And normal esophageal tubogram we do for detecting these H-type tracheoesophageal fistulas, and the contrast should drag into the esophagus and not come anteriorly. And just a brief summary on tracheoesophageal fistulas. So most commonly you would have the type C, which is this one, where you would have a esophageal atresia with a distal fistula, and so you would see gas in the stomach and the distal bowel. And other than the H-shaped ones, all of them will usually present with feeding difficulties initially early on in life and with respiratory abnormalities, and you would have the bacterial association with tracheoesophageal fistula. So this is just a case of the distal of the esophageal atresia with the distal fistula, because you can see gas in the distal thing, and you can see the tube coiling in the upper esophagus, which is distended. So slide about the recurrent chest infections and persistent pneumonia. Whenever you have persistent pneumonia or recurrent infections, think about infection with a pre-existing lung abnormality like we saw before. Think about bronchial obstruction with chronic inhaled foreign body or mucoid impaction, aspiration with reflux or H-type fistulas, which is rare but very important. I think I'll end there because I have a few more cases, but
Divya, Dr. Khan has suggested we can extend the time for a little bit if you want to go through your last few cases.
How much time will you require?
I mean, it's pretty extensive, but I guess this is good enough. I guess I've shown them a summary of congenital thoracic and some cases about infections as well. So
what I mean is that this chance they will not get again, and if we can easily extend it till 9:30. Those people who can, they will continue, and those who want to leave will leave. So
okay, sure. I can do half an hour more. I have three cases which are still.
Let's do half an hour.
Yeah.
Thank you.
I can show the next one as if any candidate wants to go ahead. It's a very good case, which is FRC.
Can I present this case?
Yeah, sure.
Yeah,
Please.
I've been provided with a frontal chest radiograph of skeletally immature patient who's showing evidence of the most prominent abnormality being a complete opacification of the right hemithorax, and there is evidence of a dense curvilinear opacity extending from the abdomen into the right hemithorax. I could not see the right hemidiaphragm separately. And there is mediastinal shift to the mediastinal tracheal contralateral shift to the left side, and there is no evidence of any pneumothorax. The aerated left lung appears normal, no pleural effusion on the left side. There is a bowel loop that is projecting over the mediastinum in the midline. And apart from this, the bones appear unremarkable, no focal lesions, no fractures. So summarizing my findings, right opaque hemithorax with a curvilinear density extending from the abdomen into the thorax, and a bowel loop that is projecting over the mediastinum. So my principal diagnosis will be congenital Lobar syndrome with scimitar sign, and that's also. I will inform my findings to the referring clinician, and I'll inform the pediatric consultant in my routine practice, and would like to do a cross-sectional imaging to confirm my findings.
Okay, that was good. But so did you say this was calcification, or did you say this was?
I think it looks more like a dense curvilinear structure.
Okay, but do you think it could be a vessel when there's a whole whiteout of the and what do you think about the mass effect, because there is a mediastinal shift to the left?
Then there can be a concomitant pleural effusion also, or there can be a mass in the thorax also.
Yeah, correct. So this is actually suspicious for a mass, because you can see that there is calcification, which is abnormal.
Then if it is a calcification, I think of a mass then.
Yeah, and you would want to go with cross-sectional, which is absolutely right. And so this patient had a CT, and okay, hang on. Yeah.
So I've been provided with a coronal and axial reformatted and axial images of contrast CT chest showing evidence of a heterogeneously enhancing lesion with calcifications and fat densities within in the right, occupying the entire right hemithorax, causing contralateral mediastinal shift. And so may I know the age of the patient?
So it's a toddler, maybe 2 years old.
2 years old. Okay. So I'm thinking of terms because of the calcification. I'm thinking of in terms of a neuroblastoma. But with the fat and everything, I think teratoma also will be a good differential diagnosis. The third to round up the diagnosis might be any soft tissue sarcoma. I would like to inform the findings and do a biopsy to confirm the same.
Perfect. So I would put teratomas first, because whenever you see calcification and fat, always it's a germ cell tumor. And this patient had a teratoma, and usually they are seen as anterior mediastinal masses, and they account for approximately 25% of anterior mediastinal masses in children. In children less than 1 year age, immature ones are more common, and they may be detected antenatally, and almost 80% would occur in the anterior mediastinum, and they always contain fat and calcification, which is the diagnostic. That is what the money is. And they can rupture, they can cause mass effect, and they sometimes can have producing hormones like HCG or TSH. So the differential diagnosis would be other germ cell tumors, thymolipoma, but that is again not common in kids. And if it is large like this, it can also be an undifferentiated sarcoma, like you said, which can look similar and like a liposarcoma or any sarcoma. And the diagnosis then would be established by histopathology only. The other thing was that always do a contrast enhanced CT in these cases, because you want to see the relationship with the vessels, because if they want to go in and excise this, they want to make sure how it is related to the heart and to the large vessels. So make sure that you always do this with contrast as well. So next case.
So I've been provided with a frontal radiograph of a skeletally immature patient. The most striking abnormality being there is opacification in the right paramediastinal region, and there is blunting of the right costophrenic angle. I couldn't see the right heart border separately from the lesion, and apart from this, the I could make out the left hemidiaphragm, and there is increased cardiac silhouette suggestive of a cardiomegaly.
Okay,
Yeah.
so where do you think this, where do you think it lies?
Yeah, I think it is in the anterior mediastinum because it's showing loss of cardiac silhouette with the right cardiac border. There is no evidence of any scalloping or erosion of the ribs.
Correct. And you can see a hilum overlay sign as well. You can see the hilum through the thing as well. So really well described. And what would you do next?
Yeah, I would inform the findings to the referring clinician, and in my routine practice inform my pediatric colleague and do a cross-sectional imaging, likely contrast and CT for further evaluation.
Yeah, well done. And this is your CT.
Okay, these are the contrast and CT images of the same patient, showing evidence of a homogeneously enhancing lesion, which is showing loss of fat planes with the vessels, great vessels of the thorax, and it is a conglomerate. Looks like a conglomerated lymph nodal mass in the female patient. And there is also evidence of a pleural effusion on the right side, and also evidence of a pericardial effusion. It's a large conglomerate mass. And there is also hepatosplenomegaly. So keeping in with these features of interpretation, likely to be a lymphoma, which in this patient. So I'll inform the findings to the referring clinician, inform a pediatric colleague, do oncology MDT, and do a biopsy for immunohistochemistry for further treatment and management, and compare with previous image.
Excellent. That's wonderful. This child actually has a new ALL diagnosis. So remember, in kids, leukemia also is an important differential for such mediastinal soft tissue abnormalities.
I have a small doubt. Is there a hydropneumothorax on the right side? I think lung window has not been provided, but
on this side, yeah, they had they've had a chest drain put in, so they would have after that effusion.
Okay.
So that is just interventional. but they had new ALL diagnosis with a white cell count of more than 100. So it is in the spectrum of lymphoproliferative disorders, and leukemia is an important differential. And this is another case.
So I've been provided with a AP erect radiograph of a skeletally immature patient. The main positive finding being here a complete opacification of the left hemithorax with the lucency in the left upper zone, causing contralateral mediastinal and tracheal shift. Could not make out the left hemidiaphragm. The right CP angle is obscured. Left CP angle, costophrenic angle is obscured. Yeah, the visualized bones. Yeah, I couldn't make out. Yeah, the visualized bones appear unremarkable. No focal lesions. So based on this, these findings of left opaque hemithorax with contralateral shift and lucency, my differentials will be a gross pleural effusion or a mass with concomitant pleural effusion causing contralateral mediastinal shift. So I inform my findings to the referring clinician, inform my pediatric colleague, and do an ultrasound chest. And if it doesn't if it doesn't solve the problem, go for cross-sectional imaging. I would like to compare with previous imaging also.
Okay, that's really good. I'm so happy you said ultrasound and that you listened to the first half of the session really well. So this is your ultrasound image, and then you also have a follow-up chest X-ray of the same patient after they have put a drain in.
Okay, I think the ultrasound image, the curvilinear probe showing massive pleural effusion on the left side. There is a hyperechoic. I don't know whether it's a collapsed lung or there is a mass there. Yeah.
Okay, and the radiograph after they have put a drain here on the left.
Okay, I think there is some increased aeration of the left upper and mid zones compared to previously, and there is the decrease in the mediastinal shift. I think there is the effusion still persisting, but it has decreased compared to previously.
Can you see an outline of a mediastinal based opacity here?
Yeah. I think there is enlarged mediastinal shadow which is going above the level of the heart. I think it is showing loss of silhouette with the cardia. So I think the lesion is in the anterior mediastinum because of the loss of silhouette with the heart.
So this is a 15-year-old, and she presented with acute breathlessness and left pleural effusion. And again, this is the CT that we did after.
The coronal contrast enhanced reformatted images showing evidence of a conglomerate mass in the prevascular and visual compartments of the mediastinum with loss of fat planes with the vessels and the heart, and there is a pericardial effusion. Apart from this, there is evidence of a hypo-enhancing lesions within the kidney and large lymph nodes in mesenteric and pelvic lymph nodes, keeping in with either lymphoma or leukemia, mostly lymphoma above and below the diaphragm.
Okay.
And inform the findings to the referring clinician and inform the pediatric colleague and do a biopsy for further evaluation.
Okay. They also have filling defects here. I'll just zoom it for you. In the pulmonary emboli, and you can see filling defects inside the renal vessels as well. I think the images are too small to actually justify that, but definitely they have lesions which are hypotenuating and involving both the kidneys, and there are pelvic lymph nodes and also like a conglomerated confluent lymph nodal mass in the mesentery.
Yeah.
And in the antemediastinum, they also have a pericardial effusion. So this patient also has a blastic phase of the lymphoma, and so basically lymphoma leukemia, you have to be aware that they are in the spectrum of what I call is SALTI. They are like the lesions which you have to keep in mind can appear as anything. So in SALTI, I consider sarcoidosis, amyloidosis, lymphoma leukemia, tuberculosis, and inflammatory IgG4 disease. So these five, that acronym of SALTI, you have to be very careful. So, and on CT, these lymphoma leukemias, they would appear as soft tissue attenuation masses. They are smooth, lobulated margin. They'll conform to the surrounding structures. So they won't really invade through, and but they would encase and they would compress the vessels. That is called the sandwich sign. They would not really obstruct them completely like aggressive tumor, but they would just go around them and sort of form around them. And you would see a pleural effusion in 50% of the cases, which is usually unilateral, as you saw, and that was a pleural deposit within the ultrasound. So ultrasound really helps to see whether there is some involvement of the pleura, thickening or nodular appearance. They also have pericardial effusion commonly, as you saw in both the cases, and less commonly they can invade the lung parenchyma and have chest wall invasion. But calcification is not common in lymphoma leukemia unless they have had therapy, and then it's post treatment related calcifications. And usually these patients, they appear dramatically, but when they are given treatment, these lymphomatous lesions, they would just melt away with near complete resolution. Always think about doing PET CT because that is the imaging of choice for complete lymphoma staging. And to assess the response to treatment, they have a Deauville score, which is usually used to see response. And the differential diagnosis would be thymomas, especially when the thymus is involved, and thymic rebound or hyperplasia post-treatment. Sometimes if they are post-treatment for other cancers as well, it might be tricky to differentiate the thymic rebound from a lesion. And just a brief thing about middle mediastinal masses, although we didn't see anything, but you would see the widened paratracheal stripes, and you would see the displaced recess, and you wouldn't see it's like the opposite of what you saw in the anterior mediastinal. So in approach to mediastinal masses, the chest X-ray is important, but always do the CT with contrast for further assessment. MRI is important for the posterior mediastinal masses, especially to assess for the intraspinal extension. And in children, you would commonly see neuroblastomas. So that is important that you look at intraspinal extension in neuroblastomas. So just a brief summary on the anterior, middle, and posterior mediastinal masses. The anterior one, the 4Ts, which is the thymus, thymic rebound, lymphadenopathy, teratoma, thymic infiltration, which can be in leukemia, lymphoma as well, thymoma, thymic cyst. Morgagni hernias are an important anterior mediastinal mass as well, and vascular malformations. Middle mediastinum, you can have lymphadenopathy, as we just saw. You can have bronchopulmonary foregut malformation. We saw the bronchogenic cyst, which was in the middle mediastinum and splaying the carina. You can have congenital vascular rings or aortic dilatation, which would also be in the middle mediastinum, and hiatus hernias. And posteriorly, you would have the neurogenic tumors. So anything neuro would be posterior, neuroblastoma, ganglioneuroblastoma, ganglioneuroma. Spinal abscesses, which can be caused by staphylococcus or TB. Bronchopulmonary foregut malformation, neuroenteric cyst, that would also appear as posterior mediastinal and usually associated with vertebral defects. Spinal tumors like Pnet and Ewing's tumors from the vertebra would be posterior mediastinal. Bokta-like hernia is also usually seen posteriorly. And obviously trauma, you can have pre-paravertebral hematomas. So this was the end of the second session.